and please do not place us on hold. If necessary, please leave the meeting and redial back in. We have allotted about 30 minutes for questions at the end of the presentations. Throughout the presentations, please submit your questions directly to the host, Rock Creek, via the chat feature on WebEx. We will convey all your questions to the presenters at the end of the session. The slides and recording, Alfred, would you advance, please?
Hey.
Sorry, those were our speakers. Next, please. Okay. The slides and recording of this webinar will be available on the GIN International website next week. Next slide. And our next webinar will be in the fall, where we will feature a series on methodology topics. Next. In August, we encourage all who can to attend the Global Evidence Summit in South Africa. The summit will feature plenaries and presentations on a wide range of topics, including but not limited to key evidence tools needed for emerging international health and social crises, how big and diverse data impact the production of systematic reviews and guideline development, the integration between evidence-based healthcare and shared decision-making, and how to solve current global controversies, and improving our understanding of how living guideline recommendations are linked to living systematic reviews. Early bird registration for the Global Summit is still open until this Friday, so please go to globalevidencesummit.org to learn more and to register. Before we get started with our webinar speakers, today we are joined by GIN North America's chairperson, Tom Getches, who is going to briefly share the steering committee election updates. Iris will speak shortly thereafter. Thank you. So, Tom, you're on.
Okay, great. Thank you very much. And thank you to the organizers for the opportunity to give you a brief update. So on my next slide, I've got some recognition, and I want to thank publicly members that are rotating off. One of these is Dr. Anna Gagliardi at the University of Toronto. She has served her maximum term, which is 4 years, and you've probably seen her name in emails and other GIN correspondence with regard to the implementation working group. So Anna, thank you so much for your contribution. Next, who's rotating off is Dr. Jose Luis Mayorga Butron. I'll tell you, it's taken me a year to be able to say that without slipping. I've really had a great pleasure of working with Jose Luis and really enjoyed his passions for evidence-based medicine and really bringing his contributions from the perspective of a practicing physician from Mexico. So again, Dr. Luis, thank you very much. And finally, I want to say congratulations to Mary Nix. She has been unanimously elected as the next chair-elect for the GIN North America Steering Committee. I'm not going to read Mary's area of focus. You'll get a chance to hear from her at future meetings, potentially future webinars and correspondence to the network about her desires and her focus as she moves into that leadership position. So I want to tell you that with Mary advancing into chair-elect, with me going into past chair, and with Sandy Lewis, our current past chair, rotating off, with Dr. Gagliardi and Dr. Jose Luis Mayorga Butron rotating off, we will have some openings on the steering committee, and there are a few requirements that you must meet to be able to serve. Your organization must be an organizational member, or you must be a current fully paid individual member. We ask that you'd participate in approximately 6 to 8 teleconferences or webinars of the steering committee throughout the term, and a term is 2 years, which can be renewed once, again for a total of 4 years of service, thus the rationale for Jose Luis and Dr. Gagliardi to rotate off. You cannot be employed by industry, and we would ask that you would make a contribution in a meaningful way. So again, next slide, there are 3 open slots. If you are interested in serving, send an email to guidelines.northamerica@gmail.com on or before Monday, July 10. I'm going to hold us to that date and not accept any applications or self-nominations after that date, just because there are a number of events that need to take place after that. So those applications, which would be your current resume or CV, in a brief statement of interest, nothing longer than 1 page. You'll have a chance, if you are elected and approved, to tell us off the page what you're really passionate about and how you'd love to contribute to the community. So the next slide, I talk a little bit about the process. So again, I'll be past chair. Melissa Browers will be current chair, and Mary will be chair-elect. We're going to review all those applications, the CVs, those statements of interest, and follow up with any questions. We would not be excluding you outright before you would come before the steering committee. We'll compile all that information and send it to the steering committee and have them rank the candidates. And the top 3 would be informed of the steering committee's decision. True to form with GIN, we are a community of GIN International, or GIN Central, as we've called it. And GIN requires that before an official appointment, you complete a disclosure of interest, or like a relationships with industry form. And then the GIN board, during their meeting in August, will review those DOIs, look at the recommendations that Mary, Melissa, and I will put forth. We anticipate that they would not deny our recommendations, but that they would wholeheartedly approve and accept and appoint those individuals onto the steering committee. So I'm not going to take any questions because I've already used the time that I was promised. But again, send your questions to guidelines.northamerica@gmail.com. You can find me on LinkedIn. You can certainly give me a call if you would like. But that deadline, hard deadline, Monday, July 10, on or before 5 o'clock p.m. So thanks very much. I am going to go into participant mode and look forward to hearing our speakers. So I think, Iris, you are next. So I'm going to stop and let you go.
Well, thank you, Tom. So actually, Alfred, go back 1 slide since we didn't get a chance to. So again, these are our 3 speakers we're going to hear from next. But before we start on our talks, it would be really helpful to all our speakers to find out who's in our audience today. So Alfred, next. So on your screens, you're seeing a polling question, and the polling panel is going to now open on your screen for you to answer. Mark as many that apply to you. So let's load the poll now. We're waiting on the poll to be loaded. Okay, on the right-hand side of your screen, you have a polling question. Please mark as many as apply to you and click on Submit. Well, it's not letting you pick more than one, so I guess choose the one that most applies to you, current role. And the poll will close shortly, in less than 5 minutes. And we're just waiting on the response, the compilation of the response now. So we're seeing on our screen the breakdown of participants. So we mostly have guideline developers. We have next highest percentage we have is of registered nurses. So we have great representation today. We have pharmacists, registered nurses, genetic counselors, other non-physician clinicians, researchers, guideline developers, educators, and other professions represented. So thank you very much for participating in that poll. We're going to now start with Iris Tam's presentation, and she is going to share the pharmacist perspective. So let's load Iris's deck, please. Thank you. Iris, you're on.
Thank you, Urado. And first of all, I would like to thank Urado and GIN North America for inviting me to speak today. Next slide. My disclosures are that I am an employee of Autonomy. I'm also a volunteer member of the Academy of Managed Care Pharmacy Format Executive Committee, and the opinions expressed today are of my own and not of my employer or AMCP. So in my brief presentation, what I'm going to do is describe and reflect upon my professional experience as a pharmacist and how I've touched or got involved with anything that has to do with guidelines. And I will provide some general considerations, and when I reflect back on, well, what kind of advice can I give for pharmacists, other pharmacists, to consider in the involvement of guidelines, I will provide a few considerations there and then some final thoughts. And then hopefully in that way I can address the two objectives that are stated there for this webinar. So next slide, please. So I started out as a pharmacist in the hospital in the inpatient pharmacy, and some of my responsibilities included developing and implementing clinical pharmacy services for patient care. So for example, setting up inpatient services to monitor patients on antibiotics and good antibiotic stewardship, as well as pharmacokinetic services and total parenteral nutrition, where pharmacists are actually monitoring and ordering drugs for the patient. And in doing so, I might be referring to national guidelines that give us guidance on how to use antibiotics or how to use drugs appropriately for these patients. And so that's where I might incorporate guidelines, or I might develop guidelines within the hospital that we will enforce to ensure the safe and effective use of our products. I also was responsible for coordinating the Pharmacy and Therapeutics, or P&T committee, where we approve drugs on formulary to be used in the hospital. And in this formulary review process and this assessment of drug therapies, we might consider guidelines in our decision-making process. Next, please. I then transitioned into a career in managed care where I worked in the pharmacy department. And in managed care, which is like an HMO organization or our payer system, I was a pharmacist liaison between the payer, the managed care organization, and our physicians. And one of my roles is to educate physicians on what's on our formulary so that they can prescribe for drugs on our formulary and do drug education. And sometimes these education will incorporate communicating guidelines to support appropriate use of the drugs that are on our formulary. So one example would be using, say, the NSF guidelines on lipid management. And so there, I have to know what are important and relevant guidelines so that I can properly incorporate that into my drug education to my physicians. We also had drug utilization management programs where we actually have pull-through programs to help physicians use drugs appropriately in our patient population. And so here, again, we might be either referring to guidelines that have already been established, or we might even create our own little mini guideline within our organization. Some might call it prior authorization guidelines, but we might have step edit programs, and they are kind of like a mini guideline, and so we would develop them in-house, and then we would implement them with our physicians to help manage the cost of drug therapy. And again, that's where I've had experience in developing kind of mini guidelines as well as using guidelines, doing education, communication, and implementation. Next bullet, please. So then later in my career, I moved into the pharmaceutical industry. Next, please. I moved into the pharmaceutical industry where I work in the medical affairs organization. Now, the medical affairs organization is firewalled and separate from sales and marketing. So in medical affairs, we are the medical, clinical, and scientific arm of the organization that supports the products that we produce. And in this role, in medical affairs, I've had responsibilities for providing medical information for our external customers, whether they're physicians and other healthcare professionals, as well as payers who are deciding whether or not to pay for a product. And in our medical information, where it's appropriate, not only do we provide information from our data and our studies, as well as the peer-reviewed literature, we might be providing information from guidelines to support the use of our products. In my roles previously in medical affairs, I've also had experience as the expert on our products. We also can inform other third parties that create medical content on information about our products. So we might be communicating to entities such as compendia, publishers, health technology assessment organizations. We communicate with ARC, as well as guideline bodies if it is appropriate. And so in this role, we would be a source of evidence and information to help inform guidelines. Next slide, please. So I also want to touch on the Academy of Managed Care Pharmacy format for formulary submissions. There is an executive committee that governs this document, and this document is basically a guideline that gives guidances to drug and device manufacturers on how to put together evidence about the product and what evidence should be in there, the evidentiary requirements that includes clinical as well as economic evidence that can be then provided to healthcare decision makers, mostly payers, as well as large hospital systems who are trying to make policy decisions, such as formulary decisions, coverage and reimbursement decisions. And so this guideline provides a mechanism for communicating information from manufacturers to payers or hospitals. Next slide. So within these guidelines, there's a lot of evidentiary requirements, like it'll say you need to include all your studies and you need to have a pharmacoeconomic model. In addition to all of that, in Section 5.1, it talks about clinical practice guidelines. And so the format suggests that the company of a product should identify important clinical practice guidelines developed by medical societies and agencies and other international organizations, identify those guidelines, and if they are relevant to the product or a comparator or the disease state, to include them in the packet, in the dossier that's being created, to summarize information and whenever possible refer back to the full guidelines or even provide a full copy of it. And so I think this is really important because those healthcare decision makers do pay some high regard to clinical practice guidelines when they are making these types of population-based decisions. Next slide. So I want to address now more looking at the objectives of this webinar, what I can say for considerations for pharmacists. In terms of developing guidelines, I have to admit I've never participated on a guideline body that developed national guidelines. I've not had that opportunity. However, at the national level, at the society level for these big guideline bodies, pharmacists can find opportunities to actively volunteer on these guideline bodies. A good guideline includes all stakeholders, and where it's appropriate, a pharmacist could be a great stakeholder when it comes to drug therapy. And also pharmacists can find opportunities to provide, even if they're not on the guideline body, they can provide input or comments via appropriate methods. Some guidelines in their process will entertain public comments, and so pharmacists who might have good input can provide those public comments through those appropriate methods. Next slide. But at a more local level, pharmacists can find opportunities to improve care or process by developing, what I previously called mini guidelines. So while I was at the hospital, I was involved in creating these guidelines for our institution. That's very specific to our institution. Again, when I was in managed care, I was involved in developing guidelines that we implemented to meet our needs. And so my general recommendation to pharmacists is look for opportunities and really get involved when you can. Next slide. In terms of evidence review and critical appraisal, I think this is where pharmacists can have a lot of play, because as pharmacists, we are the drug experts, right? And we have been trained in reviewing the literature and critically appraising studies and interpreting the literature and then trying to apply it in the real world. But one of the number one thing I would say is if you're a pharmacist or if you're anybody on this panel that's a non-physician, I highly recommend you to get acquainted with the IOM report on how to develop trustworthy guidelines. So there's links at the bottom here. These are publicly available. The first one is how the tenets of what a trustworthy guideline is. And I can tell you there's a lot of guidelines that are done out there without going through all these steps. And then the second document is actually a very specific document that touches on one of the tenets, which is that guidelines need to be based on a systematic review. So that goes, it's a deep dive into the systematic review. So my recommendation or my advice to pharmacists is, oftentimes if we're involved in, say, creating a guideline within our institution, we may not follow all these, but it's really good to know what the gold standard is. And I find it really helpful to just have in the back of my mind what perfect looks like, even though in reality we may not meet all these requirements that are spelled out by the IOM. So I can't stress enough how helpful it is to have this knowledge in your back pocket. Next, please. And as pharmacists, whenever we are either applying guidelines or involved in creating guidelines, we can just remind ourselves all the different sources of evidence that you can obtain. You can get the peer-reviewed literature. There is FDA-approved information. ClinicalTrials.gov might have some information that hasn't been published yet. There are third-party references and compendia and other sorts of reports and assessments like ARC, there's OHSU, the DIRT Project, and others. And then, manufacturers, although oftentimes guideline bodies do not consider them a stakeholder, but if you happen to be making decisions on guidelines regarding particular products or classes of products, the industry might have data that might be helpful to you that is not in the published peer-reviewed literature. Next slide. And then in terms of implementation and evaluation, for pharmacists, you can play a role in communicating and educating about guidelines that are available or maybe guidelines that have been updated. Pharmacists can also play a role in interventions and recommendations because, let's just give you a quick example, a pharmacist in a hospital might get an order for a drug for a patient and after reviewing it realizes that there might be a better alternative or choice based on guideline recommendations. And that pharmacist can call the physician, have a discussion, and suggest or recommend based on the evidence, based on the guidelines, and see if the physician might want to take a different course. So that's something very commonly not uncommon for pharmacists to be involved in. Next, please. And then evaluation. So how good are guidelines being followed? What's the adherence? I compare this to the drug use evaluation process, which pharmacists are very familiar with, and that is going back and looking to see if the guidelines recommendations have been followed. And then keeping in mind that guidelines are guidelines and they're not mandates or absolutes, so you need to allow for variation. And also keeping into mind when you're doing the evaluation, is the end goal around quality of care or versus just measuring a process? So how useful is your evaluation, and do you want to target it to something that is more valuable than just a process measure? Next slide. So just some final thoughts for pharmacists specifically. You are the drug information expert, and in guidelines where and not all guidelines are just about drugs, but if it's about drugs, then I think pharmacists are a wealth of resource. And so for the other non-pharmacist people on the call, if you're a guideline developer, think about including your pharmacist in the development process. Also, I really believe that pharmacists are valuable because they have cross-therapeutic knowledge. And because of the training, even if they didn't work in a certain therapeutic area, they can quickly learn what they need to learn around the drugs and the therapeutic area. And so they're very versatile in that respect. Whereas sometimes, physicians, if they're cardiologists, they're not really going to be helpful in oncology, say. And pharmacists may be able to provide valuable insight in other perspectives because they might have a multi-stakeholder perspective because they interact with the nurses as well as the patient, as well as the doctors, as well as the respiratory therapists and whatnot. Pharmacists come from different multiple settings. So you have retail pharmacists, ambulatory care, you've got those in managed care as well as hospital. And so they might be able to provide input that is just above and beyond the science. So next please. There are challenges for pharmacists. First of all, they may not have the time or the money or the resources to get involved in all the things that I just mentioned. I also believe over 25 years of experience, sometimes pharmacy is a forgotten discipline or functional stakeholders, and it's not just about guidelines, it's in other areas too. And guideline development is not a natural in our professional repertoire oftentimes, but it is definitely a area of opportunity for pharmacists. Next slide. And here's my contact information if anybody wants to follow up with me offline. Thank you.
Thank you very much, Iris. That was quite informative. So I just want to remind everyone on the call to exercise your opportunity to ask questions to our speakers. And you can do that by clicking on the chat box on the top right of your screen and then submit your questions to the host, who's named Rock Creek. And whatever questions you submit to Rock Creek, we will convey to our presenters at the end of the call. So let's move on to our second speaker, who is going to be Dr. Lucia Costantini from the Registered Nurses Association of Ontario. Lucia, you're on.
Thank you. And the nurses, we love the pharmacists and consulting with them in our work. If we can go to the next slide, please. And the next one. There we go. Okay, so I want to thank you all for including me in the session today. I'm going to just give a brief overview of what the Registered Nurses Association of Ontario organization is all about and our guideline development process, just to give you a little bit of context. I won't spend a lot of time on that. And then I'm going to get into more detail into the guideline development process that we use here. Currently, we're in the early stages of aligning our methodologies with GRADE and GRADE CERQUAL frameworks. So the process that I'm describing today might be modified in the future as we move through this change. Next slide, please. The Registered Nurses Association of Ontario is a not-for-profit organization that advocates for excellence in nursing practice for the RNs, nurse practitioners, and nursing students in Ontario. We currently represent about 41,000 members, and we also actively engage in healthy public policy, and that includes strategies such as addressing health inequities or reducing homelessness, among several other areas. So when we write our guidelines, we are mindful of the political context in which our topics occur. Next slide, please. Our program is funded by the Ontario Ministry of Health and Long-Term Care, and it has been since 1999. Our primary objective is guideline development and its active engagement in its dissemination, implementation, and evaluation. So to support all these areas, we partner with healthcare organizations globally. Currently, we are working with 101 organizations that extend over 500 sites in Canada and other countries, including Spain, Italy, China, Australia, Jamaica, just to name a few. Next slide, please. So this is an overview of our program. So we have the three arms, the guideline development, and then our implementation and evaluation and monitoring. So I'm going to focus primarily today on the guideline development. Next slide, please. So we felt that it was important that we, given that this is a primary goal of our program, that we develop our own nurse-led guideline definition. So we have evidence-based statements that are for nurses and the interprofessional team. So while our primary focus is on nurses, we recognize that the nurse is one member of the larger team, and we aim to write recommendation statements that are applicable across the interprofessional practice. And we also want our guidelines to inform educators, policymakers, and patients and their families. Next slide. So we currently have 41 clinical practice guidelines and 12 that focus on system and healthy work guidelines. Next slide. So this is not an exhaustive list. You can go to our website at rnao.ca for the complete list of our guidelines. So this is just a sample. We're currently working on a breastfeeding guideline, and we are drafting from cover to cover the safe injection site guideline. That will probably be out in December or January of 2017-2018. Next slide, please. We also just started work on an end-of-life guideline. And our Falls guideline is nearing completion and should be published within the next couple months. Next slide, please. And this is a library of our system and healthy work environment guidelines, and we just started work on violence and harassment in the workplace. So we anticipate that guideline will be out in approximately a year's time. Next slide. So this is the 6 steps that we follow when we develop our guideline process, and I'm going to go over each of these steps in a little more detail. Next slide. So to select topics, we obtain topic ideas from our membership and external health professionals and patients. We also obtain ideas from government, and we look for trends in the literature. Once we have a topic idea, we will do a gap analysis and some focus group interviews. As we are in the process of aligning with GRADE, we're looking to put more structure around our gap analysis to create better transparency. We're also considering conducting surveys so that we can examine key areas and include more experts in the initial process, as well as persons with lived experience. Next slide. Once we complete that work, we assemble a panel of experts. It normally includes about 20 experts with 2 co-chairs, and we try also to include persons with lived experience. We seek out individuals from diverse health sectors and backgrounds and geographic locations. We anticipate that this will not change significantly once we're moved forward with GRADE, but one thing that we are trying to address is when we meet with our panel, we're currently discussing strategies to explain the evidence tables based on the grade criteria. Next slide. This is our systematic review process that we follow when we develop the guidelines. The first 3 steps, literature search, title abstract, and relevance review will remain the same, and our critical appraisal and research summaries we are modifying to fit with grade and grade CERQUAL. So we use our research summaries to build our recommendation statements. Next slide. So to the summary of evidence, which is consistent with grade, we are going to be adding the patient preferences and the benefits and harms as part of our, routinely as part of our guidelines and recommendation statements. We are also considering adding health equity as another dimension to our evidence summaries. Once we reach this stage of the process, we do an in-person 2-day build with our panel to obtain consensus, and we use a modified Delphi technique to vote on the recommendation statements. We have to get all the feedback from the panel and then use that to revise the recommendation statements as necessary, and then we begin the process of writing the guideline from cover to cover. Next slide, please. So once we have a draft of the guideline, we have an internal peer review process followed by an external stakeholder review, and then we take all the feedback from our stakeholders, make revisions as appropriate and needed, and then it will go to editing, final editing and publication. Next slide. So our stakeholders, we use our website to try to invite experts to provide us with feedback on our guideline. We will also send out invitation to experts known in the field and centers of excellence so that we can get a robust feedback on the guideline and the recommendation statements that we're proposing. Next slide. So once we have all this evidence, we move forward with our implementation and evaluation process. But today, like I said, we're going to just focus on the guideline. So if you can move to the next slide. So some of the learning opportunities that we have encountered as part of aligning with grade, we have, as I've shown you, a lot of diversity amongst our topics that we try to address as part of nursing practice. And as well, when we're writing our guidelines, we cut across all health sectors and adults from a diverse age group. So this can potentially mean that we will have to use different adaptations of grade depending on the topic that we are looking at for guideline development. In addition to that, some of our topics will include quantitative and qualitative research. So, for example, the end-of-life guideline that we're currently working on, our panel and co-chairs felt that it was very important that we not eliminate literature based on study methodology. So here we're looking at writing our recommendation statements based on both grade and grade CERQUAL frameworks and including them in one guideline. In terms of resources for our guideline developers here at the RNAO, this means that their expertise has to stretch across several study methodologies in both the quantitative and qualitative fields. And in terms of the life cycle of our guidelines going forward, they will not be revisions, they will all be new additions so that we can consistently include the new framework and our new process in all our guidelines moving forward. So we're very excited about this work, and that about wraps it up for me. Next slide. That's it.
Thank you very much, Lucia. So next we're going to hear from Deepti Babu, who's representing the National Society of Genetic Counselors. Go ahead, Deepti.
Thank you, Gerardo. I'm really happy to be speaking today alongside Iris and Lucia. And thank you to GIN North America for asking me and the National Society of Genetic Counselors to be a part of this really important conversation. I can see from the original poll that we did that I think there was one genetic counselor in the audience, and most of the audience was guideline developers and a smattering of really other healthcare providers. So many of you may know what genetic counselors do in the healthcare system. We're increasingly found outside of the healthcare system lending our expertise, but a common theme is that we are helping to educate patients and individuals that are making decisions about their genetic health, which is becoming increasingly understood as our evidence base grows. So you might find us in a clinical setting or outside one, such as doing research or in a laboratory, commercial industry setting. And today there are more than 4,000 certified genetic counselors. The NSGC is the genetic counseling professional organization in the U.S. and has members worldwide, including me. I'm based in Edmonton, Canada. And the NSGC works with other professional organizations worldwide as well on shared endeavors. But my role is has been quite honored to be the chair of the Practice Guidelines Committee in 2015. I actually rolled off the committee in January, but I think largely because of the scope of the work that we did together, I still feel very connected to the group, and some of them may be listening today, so just a quick shout out to them. Today I'm going to be providing background about how the NSGC worked to really transition our clinical practice guideline process to one that incorporates systematic evidence review. It hadn't previous, and we had many reasons for doing that. And it was really quite a sea change for our organization and a labor of love. We're currently in the early operational phase of this transition, but we've learned a lot of things along the way already. Just to give you a sense of the structure of the committee, it consists of currently 18 volunteer members, a board liaison, and a staff member from the NSGC's management team. So it's really lean and mean. The staff member handles the bulk of administrative tasks and scheduling, and the rest of the work falls on the committee members to do in the quote-unquote spare time that they have, and like everybody, incredibly busy and have a day job to hold down. The committee often divides into working groups based on need and special topics that need focus, but they're also assigned to work on regular tasks and liaising with guideline author groups. So kind of the background. Alfred, if you wouldn't mind changing the slide, please. So just a disclosure slide for me. I'm a full-time paid employee that has stock options at Think Genetic Incorporated. My role with Think Genetic is really to hone our communications and our relationships with the patient community, and I kind of serve as the voice of the patient through our communications and our content. I work with multiple teams to do that. Everything I'm saying today are my opinions, and they don't represent my employers. I don't plan to present content that refers to this role, but just wanted to disclose it here. Next slide, please. So in 2013 to 2014, we kind of had a deer in headlight moment, which was we really probably need to evaluate our guidelines and make them evidence-based for many reasons, including the IOM standards that predated that. But the National Guidelines Clearinghouse inclusion criteria, meaning that they required that guidelines be based upon a systematic evidence review, really went into effective June 2014, and we became quite aware that we needed to respond to that. This was not an easy thing to think about, and I think that there were some aspects to genetic counseling guidelines that made it particularly tricky. The definition of a medical intervention is not a drug, a device, or a treatment in the context of genetic counseling. It's the process of the counseling itself as the intervention. And our guidelines may be written to guide a clinician providing genetic counseling for a particular patient population. It could be a guideline to determine the format in which the genetic counseling is delivered or some other topic. Unfortunately, our evidence base is still emerging. So to have an evidence review is kind of challenging. But nonetheless, we acknowledged that these standards and the inclusion criteria for NGC were good reasons to think about making a change. And we had our own reasons from a professional standpoint as well, because, you know, as we continued to make our guidelines more rigorous, it would better demonstrate the value of genetic counseling and that the genetic counseling can improve patient outcomes. We would also think that it would inspire good research, increase the evidence base, minimize bias, increase transparency, and really increase the trustworthiness of our guidelines. So all good reasons. But we did recognize, so prior to 2015, our guideline authors assembled themselves. They proposed their topic to the Practice Guidelines Committee, and they went through several stages of review with independent expert reviewers, ethics review, board review, and they were all published in the Journal of Genetic Counseling, or aimed to be published there. A systematic review is not required. So we knew we had to get there, but we didn't know the destination or the path, which is why this road sign is unmarked. Next slide, please. So from that point forward, we began to see really the scope of this, and we had to remember that even after a storm, a rainbow can appear. We really had to remain committed to do the work to reach the tougher solution, even if easier ones were available. And our biggest challenge, I think, would be writing evidence-based guidelines in a field with an emerging evidence base. Next slide, please. So one of the first tasks was we had a subcommittee that we convened to canvass external groups, really to kind of learn from those who came before us. We felt like we were pulling paints of different colors together to build a new work of art. One thing we realized quickly is our group was small and not made up of people dedicated to these tasks, because again, everyone had a day job they needed to do and other things going on. But we found some great resources, including the American Academy of Neurology, and Tom Getchis was, whom you all know, was with the group at the time, was incredibly helpful to us to share materials that the AAN had developed. The Society of OBGYNs of Canada was also extremely helpful and just basically turned over their materials to help us, which was fantastic. I'm taking notes from today's presentation, and we'll be going back and suggesting those kinds of things to think about even more for the Practice Guidelines Committee. Next slide, please. So then we began to understand what we needed to do, and then it was almost like this massive period of synthesis. So we had to bring all of this great information into focus and figure out what were the priority tasks. And then we need to also kind of get support from not only the committee, but the board and the leadership of the NSDC, because we needed their support in many ways, including financially. So we put forward proposals to have myself and my co-chair trained at the New York Academy of Medicine's seminar on evidence-based medicine to get really immersed in this conversation and put us in good position with other groups to network with them and leverage resources. And then we also were able to get support for an in-person meeting, one day-long meeting with the most packed agenda you could imagine of our entire committee, all flying out for this concentrated opportunity to educate them about this, and it was incredibly helpful. And we're very grateful to have had that support from the board, because we just couldn't have done it without them believing in this project from the top. Next slide, please. So once we actually came together about what we needed to do, then we needed to actually hit the ground running with it. So we created essentially a manual for our new evidence-based practice guideline process. It's essentially a living document. It's like we change one thing and change it the next, and we know that that's going to be the case going forward with it as well. So we essentially rolled up our sleeves, got our hands dirty, and started writing. And this was primarily between myself and my co-chair for setting the base of it, but then we would develop smaller groups of our committee members who would essentially create content, and we kind of all mashed it up together. It was really a group effort. Next slide, please. So as we were writing the guideline manual, this is now 2015, we felt like every time we took some steps forward, we'd come back because we'd realize, wait a minute, this is a topic we need to delve into more. Let's take that sideways, develop a subcommittee to learn more about that, and then come back and give us the recommendations. Every time we did that, it was it felt like we were losing progress, but in the end, when we completed it, we had thought through so many different scenarios that it felt obviously that it was worth it, and it was far better for it in the end, because now when we're in the operational phase, that manual gets referred to quite often for situations where it was like, hey, did we think about this? Actually, we probably did. Let's look and see what it says. So some of those topics that we ran into right away were, we have these great guidelines that we're aiming for. That's the gold standard, that are evidence-based, based upon a systematic review. But what about if you just can't do a good systematic review and you still need that clinical guidance for that particular topic? We formed a different category for that and called those practice resources so that they could still be of use, because that is the whole purpose. But it would have the appropriate caveats within it in the language to almost just be like a reference document. Conflict of interest. We developed our own survey for the Practice Guidelines Committee for our author groups and for our own committee members to complete. That was not in place before in this robust fashion. It's electronic. It's pretty slick. Guideline renewal, reaffirmation, and retirement. We had a lot of great guidelines that were out there, but are they still guidelines in the context of this new definition of evidence-based review? Maybe not. So we had to consider, how do we deal with those? And not to mention, how do we engage those authors and let them know and sort of do that in a respectful manner? Topic nominations was something that, again, authors would come to us with ideas. We wanted to be the ones that were also kind of a little bit more engaged in that process. So putting out ideas to groups proactively was something that we incorporated, and we formalized the process for this. Meanwhile, we were getting lots of requests for endorsement of external guidelines. How do we handle those? What do we do with those? And retiring our old documents that became obsolete. Next slide, please. So I think Lucia mentioned their 6-step process. I was thinking, ooh, ours is 12. I won't go through all of these because they're very detailed, but this is part of the manual that we developed and often gets referred to. I just want to point out some key changes that we identified as we developed this 12-step process, which is we required systematic evidence review. That wasn't part of our process previously. We had a new conflict of interest disclosure survey specific to us. That's part of this process now. Again, the practice resource document as an alternative if the guideline cannot be achieved is one. We removed expert review because now it's being replaced with systematic evidence review. We added an NSGC member comment period. That wasn't the case that we had before, and external stakeholders. And we also included consideration of submitting these to other journals along with the National Guidelines Clearinghouse. Next slide, please. So once we had this laid down, we thought it was great, but we needed to make sure that other people would think it was great, including authors that had written guidelines for us before, and doing that in a respectful manner again. So we really thought of ourselves as ambassadors for the process. Everybody on the committee was committed to promoting it. And we wanted it to be open, inclusive, and really honoring what had been done by our members before us to get us to this point. So we sent emails to the membership to educate them about the new process, to give them information that was enough to pique their interest without overwhelming them. Engaged our special interest group leaders to target members that might be good authors. At the annual education conference that we had in the fall, we had sessions sponsored by our committee and that were speakers of our committee, including using some external experts on guidelines, some that we had met at some training. So it was a really great opportunity to showcase our new process, get people excited about it, and enable them and empower them to think that they could do it. Next slide. Then we had to do it. So in 2016, when I was the past chair, the chair at the time, Jillian Hooker, got the guidelines going in the pipeline with the committee and her co-chair. So we had a call for topics to the membership, during which time we got 11 proposal forms submitted with 8 emails with ideas, and that led to 3 topics that were approved and 3 guidelines that are currently in the pipeline with author groups. I failed to mention that one of the things we did with the author groups is split them. So now, instead of one author group taking everything from the start to finish, we have a systematic review author group and then a guideline author group. So separating a little bit of that out. So there are 2 author groups for each guideline that we're managing now. And we're doing a review of existing guidelines to see where they stand. They should be retired, if they should, maybe they should be moved into a practice resource category, things like this. Next slide. So like I mentioned, we have 3 guidelines currently in process. One is on genetic counseling for individuals that have hypertrophic cardiomyopathy. Another is genetic counseling for individuals that have epilepsy, and the third is telephone-based genetic counseling. So in that sense, the guideline for determining the effectiveness of using a different modality for genetic counseling than what is typically done, which is in person. So we held a second open call for proposals earlier this year, and we've started to review them in the committee. So far, the committee has approved 2 additional guidelines, so hopefully that will mean 5 are in the pipeline. We also recognized we needed to really flesh out the practice resource process on how to actually do them instead of just defining them as a category. So we're just kind of in the phase right now of beginning the actual writing for these with our various author groups, which is exciting. And engaging ongoing topics. Next slide. So we do know that there will be some challenges. We've identified them already, and some of them we've known about. We've just been, trying to deal with the priority of beginning the process before we really flesh out how to deal with the challenges here. One of those is how do we build resources for our guideline author groups, such as how do we find this specialized expertise for systematic review? It's not easy to find. And we've been engaging author groups that may have access to individuals with that methodological expertise. But going forward, how do we arm our authors with that so they may be able to have that already? Another thing that we really want to work on is how do we broaden our author groups to include people who are not in the genetic counseling field, patient groups, advocacy groups, policy groups, other healthcare providers, like pharmacists, nurses that we've heard today. And how do we implement our guidelines and evaluate that whole process? It's one thing to have it published. It's another thing to measure, is it being used? Is it being used effectively? And is it changing patient outcomes? That's what we really want to know. And we'll get there. I mean, I think that this whole process getting to this point, I'm so proud of everything we've been able to do. But we're lean and mean, and we'll remain nimble with our seatbelts fastened because there will be more bumps along the road, and we'll kind of cross them when we get to it. I think learning from those who have gone before us, such as the speakers we've heard today and others, will certainly help quite a lot to gain from their expertise. So I'm really glad to be a part of this conversation. Next slide. And the whole theme of this is it really takes a village. So I think I've mentioned it a few times. Our amazing committee members and our staff liaisons couldn't have done it without them. And really special thanks to the leadership for believing in this, even though it was like, this is a really complicated topic and we don't know how to get there. They really took a lot on faith. And our past chairs that have really positioned us so beautifully. And special thanks to some of them and one of our committee members, Jamie Natoli, for their slides that I worked on with them. And next slide. This is just the, how to get a hold of us. So Erin Carmody and Tony Polin are the current guideline chair and vice chair of Guidelines Committee. And we do have a website where we have a lot of our materials, and then my email is just at the bottom if you wanted to reach out to me. Thank you again for the invitation to speak. This has been great.
Thank you so much, Deepti, Iris, and Lucia. Those were very insightful presentations. As a physician-oriented guideline developer myself, I think I can speak for other physician-oriented guideline developers when I say that we take it for granted. I see that all the resources available to us and all the already well-developed processes we can adapt and adopt that you've had to develop from scratch for your organization. So I really appreciate the work that you've done thus far and the work that you're continuing to do. But you'd be surprised as to how we face similar challenges, especially in the implementation realm or assessing the value and impact of our guidelines, especially after contributing so many hours to their development. So thank you again for presenting. So we have a number of questions that have come in through the chat feature, and I'll start right away in the interest of time. Let's see, the first question we have is for Lucia, Dr. Costantini, and the question is that you noted that in your stage 2, a gap analysis is conducted. Would you please provide some elaboration about the focus of the gap analysis? Specifically, is this an analysis of variation in clinical practice? If so, how is this data obtained?
Sorry, I just didn't hear the last part of that statement. Can you repeat that, please?
Sure, I'll repeat the whole thing. In stage 2, you noted a gap analysis is conducted. Would you please provide some elaboration about the focus of the gap analysis? And specifically, is this an analysis of variation in clinical practice? If so, how is this data obtained?
It's not necessarily looking specifically for variations in clinical practice. We recognize, we know from our interactions with our organizations that there are variation in practice. So when we do the gap analysis, what we're looking for is, because there are a number of guideline development activities that are now occurring, we look at existing guidelines that are in the topic and what do they address, what sort of recommendations do they make, are they applicable to nursing practice, where are their deficits in those areas, and to help better inform whether it's even a topic that we should be pursuing.
Great, thank you. We have another question for Deepti. So I think that some of the topics you addressed, Deepti, were for counseling patients who have these genetic disorders or conditions. Do you, in your guideline development work, at all incorporate the evaluation of the ever-increasing commercially available genetic tests? And if so, do you apply a different type of critical appraisal when looking at those tests or products?
Yeah, that's a great question. So, I mean, the counseling aspect often incorporates how to assess the genetic testing, how to break it down and find the ones that are appropriate for a particular patient, and then how to select, how to ultimately use that result in framing the conversation. That's what a lot of genetic counselors do. And so they're perfectly positioned to be analyzing that. And we did have quite a lot of conversations on the committee about, if you have a guideline author that's part of a commercial diagnostic testing laboratory, is there a conflict there? So one of our determinations was that we cannot have somebody in industry be one of the lead authors. And so that's also kind of assessed in our conflict of interest survey. Not only are you in an industry-based position, but really, does that actually pose a conflict to the information that you're going to be analyzing? Because the fact that you're in industry shouldn't preclude you from it alone. It's really about whether that causes an actual harm or bias in the information that you're presenting. And so we did have quite passionate conversations about this, actually. But it's tricky because the individuals that are working in a commercial setting, perhaps in a laboratory, have a lot of expertise. So to leave them out of the conversation is kind of, it's not complete. So I don't know if that answers the question, but the discussion of genetic testing is often part of the guidelines.
Great, thank you. I think the discussion of incorporating industry and biases leads us to a question for Iris. So Iris, have you ever been in a situation where the only data available is from industry? And if so, how do you manage or address the inherent biases that come from drug data, specifically from industry?
Great question. I can't come up with an example where the only information is from industry, but in terms of addressing bias from the industry, I certainly understand the precautions that guideline bodies have about industry involvement, the bias from industry, and all the issues around conflict of interest. And there is no like one right answer, but it is my personal belief that it's all about transparency and let's focus on the data. So if industry has information, and it could be published and unpublished data. There could be reasons why a company has unpublished data, but for whatever reason, they're not willing or able to even disclose it. But regardless of whether it's been published or not, information from the industry or input from the industry, you know, I feel can be handled objectively. I mean, let's look at the evidence and let's critically appraise the evidence that's being presented by industry as you would with anything else. I firmly believe that everybody, every stakeholder has an interest of some sort, right? So if we all just focus on the evidence and appraise the evidence according to how we've been trained in the scientific methods, then you know, it could be a great source. I also encourage guideline bodies to view industry, if your guidelines do involve a lot of products that come from industry and commercial entities, is to challenge, go back to them and challenge them to say, hey, this is what we're doing, and give them the opportunity to provide the evidence, because let them do some of that legwork of, you know, coming up with the evidence that will supplement your literature review and systematic review. It's not going to supplant it, but, you know, see them as a scientific resource. And also, after you've developed your guidelines, take the opportunity to present back. You know, you can get input, and they might have information that might supplement, you know, what you've already come up with. And also, if you come up with gaps where you want to make a decision or recommendation around something and you just don't have enough evidence, you know, share that insight with the industry and say, this is where we really need information for our patients, and challenge them to do the research, because they're the ones with the money to do the research.
Great, thank you, Iris. Another question for you, Iris. Does the Academy of Managed Care Pharmacy provide opportunities for pharmacists to take part in medical society guideline panels? And if so, would you please share how one could be involved in that in case we have pharmacists online who'd like to join that process?
Yeah, the Academy of Managed Care Pharmacy, it is a professional organization, the premier organization for pharmacists who work in the managed care space. So the members are members who typically work for managed care organizations and payers, and so their interest is around population health management. They do not, I don't see how they would have any, they currently don't have any ability to get pharmacists on, say, the AAN guideline body or the AHA guidelines. That's not their role, and they don't have any mechanisms to do that. That directly answers your question. But for outside of that, I think there are some guidelines that include a pharmacist, but it's I think both ways too, encouraging guideline bodies to, you know, include pharmacists and recruit pharmacists for their guideline bodies.
Great. I hope they're all hearing you today. So this would be the place to make that pitch. Great.
Yeah.
Thank you.
And then for pharmacists, just ask to be included. You know,
right.
the format committee that I sit on, it's a body that creates guidelines for the dossier, so it's somewhat a different set of guidelines, you know. But I actually went to the committee members and asked to, I volunteered, I contributed, and eventually they invited me to be on the committee.
Great, thank you. Lucia, we have a question for you. So you mentioned that you incorporate persons with lived experience. That's very much in alignment with the great effort in the general guideline community to include consumers on their guideline panels. Would you please elaborate a bit on your process of incorporating persons with lived experience? Do you pursue a special training for those persons to provide them with some sort of general research background, or I guess, and please describe any of the process with which you incorporate those people into your panels.
So, yes, thank you for that question. So what we do is when we try to engage experts in the field, we try to use a few different strategies here. We also have like other programs in terms of, we have a public policy program. So there are people with, when I say people with lived experience, I'm referring to if we're writing a guideline that's related to cancer, someone who's actually had the experience of having cancer or that has the chronic illness, someone that's had an end-of-life experience and so forth, that would like to participate. We have a patient advisory council, so those are individuals with lived experience. So we would draw on them if they know someone that has experience with a particular topic that we're doing the guideline on, or if the experts know of someone that they could send an invite out to try to include them. We don't necessarily provide them with specific training. What we do is when we write our research summaries and when we write the guideline in general, although it's directed to health people in the healthcare sector, we try to write it in a fashion that is accessible and readable by them as well, and then we would just support them with a glossary of terms and so forth for like more medical terminology that we can't simply put into layman's terms. When we launch a guideline and assemble the panel, we also have like an in-person meeting in order to do that, and they get orientation as panel members where we give them, provide them with steps through that process in order to try to provide them with some fundamental foundations. And we also engage in this process because we want to try to make it as unbiased as possible and incorporate their feedback when we write these recommendation statements if the persons with the chronic illness and so forth feel that they are being accurately represented when we're looking to provide care to them. Does that answer your question?
Yeah, I think that was a great answer. We have another question for you, Lucia, since you mentioned that you are embarking on implementing GRADE. So when you search for literature, especially in some nursing literature, doesn't necessarily lend itself well to GRADE. There's some translational research. How do you incorporate sort of the non-RCT type nursing literature into GRADE, or have you not worked that out yet?
We are in the preliminary stages of doing that. So we have pilot tested some strategies that we're going to use in order to meet that goal. So there is literature on GRADE that provides some structure around how to apply GRADE when you're going to don't have statistics, and to do it in a narrative fashion. And there's also articles written on GRADE Cirqual that tells you how to do an evidence-based synthesis of qualitative data. So we plan on using those modifications of the GRADE framework to address that.
Great, thank you. We have a question that applies to all three of you, and the question is, are librarians or other information professionals who have expertise in literature searching members of your teams or author groups? And if you don't incorporate librarians, who does that searching for you? Deepti, do you want to go first?
Sure. We definitely identified librarians as an absolute gold mine for that skill set, and that was something we put into our manual. Now, I'm not aware of the details of the author groups currently because, again, I've rolled off the committee. There may be librarians that are part of the systematic review author groups already, but we've definitely made it a very strong recommendation to consider engaging them.
Great. Iris, I don't know if you work with librarians who do specific pharmacy-related searches. Do you?
Yeah, I did not have the luxury of having a librarian in the hospital setting or the managed care setting, so it's really us pharmacists, using our drug information training to find information. At my prior larger industry company, we did have a librarian dedicated to the Medical Information and Drug Information Center so that when we had complex questions, we did have access to a librarian to do more rigorous research.
Lucia?
Yes, we do use several health science librarians. We have some that are affiliated with academic health science centers and others that are affiliated with a local university. So once we determine the scope, the purpose, and our research questions, we will engage them at that point, and they guide us through to make sure that we have a really robust literature review.
Great, thank you. So we have one final question that also applies to all three of you, and I think I've been involved in upwards of 30 of these webinars, and we get asked this question all the time, and I'd be very curious to see how you're going to answer it as it applies to your professions. And it's a very general question about guideline development. How do you address the issue of guideline development when a systematic review shows insufficient evidence? Any takers? Deepti, did you encounter this when you were developing your first guidelines or with your new process?
We encountered that this would potentially be an issue because, as I mentioned, the evidence base is emerging for our field. So that's why we incorporated this idea of the practice resource, which could be something that could be pursued and set up the stage for a clinical practice guideline going forth. That's one option. Again, we're in the process of writing these, so we haven't encountered this just yet, like the systematic reviews haven't been completed yet. But the other thing is you could frame recommendations with that caveat. So that's another thing to consider.
So your practice resource product is more of an evidence-informed document than your clinical practice guideline.
Right, that's the way that it's currently set up, because we didn't want to discourage our authors from pursuing things that would still be valuable in the clinical space.
Sure. Iris and Lucia, do you have a comment on this as well?
So it's Lucia here. So we have a few things that we try and do when we come up against this issue. We will look at other high-quality guidelines. We will also engage with our expert panel, and we also will communicate with our best practice spotlight organizations. We have over 500 around the globe so that we can speak with clinicians in the various practice settings and determine a solution to address that.
Great, thank you. Iris, do you have anything to add?
Yeah, so these are just off the top of my head some options. Not that, again, I've not been on a big guideline body to deal with this, but depending on what the issue is, I would say you may not be able to say anything or don't need to say anything. But if it's an issue or question that really deserves action, as I heard one guideline body person say to me, well, just because there's no evidence doesn't mean that we're not going to treat the patient. So short of not making a recommendation, you can make a recommendation based on theoretical principles and based on mechanisms of action or the science, even though you don't have the clinical data. The next option would be to use lower level of evidence. And as mentioned earlier, the last resort is using consensus from your physician panels. And so it would be more scientific opinion and physician consensus.
Great, thank you. We got another question in for Deepti, so we're going to continue. If they're going to write guidelines for selecting tests or panels, do you take cost-benefit into account, such as number needed to treat, QALYs, or other health utilities?
Yes, my understanding is that would be considered in the analysis and the decision-making, because that's considered in the clinic anyway.
Great. I think that brings us to our, concludes our presentations today. We do not have any more questions. Thank you so much for our speakers for participating today and answering all our questions. What you're seeing on your screen, everyone, is the URL for where the recording and slides of today's webinar will be posted within a week. And we thank everyone for your time. And if you have any follow-up questions, please submit them to us. I think all of the presenters provided their email addresses in their decks. So thank you, and we hope you have a great summer. See you in the fall. Thank you.